So our objectives are to review the vital neuroanatomy of the pelvis, literature of pelvic surgery, as well as describe the technique and outcome of a hemisacrectomy case. So Toby is an 8-year-old male neutered mixed breed dog that presented to the surgery service for a 1-month history of a progressively enlarging right-sided hip mass, hyporexia, weight loss, hematochezia, right pelvic limb lameness, and hip pain. He was previously treated with tramadol and a 3-week tapering course of anti-inflammatory prednisone by his primary veterinarian. He represented with enlargement of the mass and persistent pain. On representation, staging was performed and included a CBC chem, bineal aspirate, and thoracic radiographs, which were unremarkable or inconclusive. Pelvic radiographs performed revealed an aggressive osteolytic and minimally osteoproductive lesion involving the right iliac wing, as seen here by the green arrows, with an associated soft tissue mass dorsal to the right ilium, as seen by the yellow arrowheads. Punch biopsies obtained 24 days after presentation revealed a high-grade sarcoma with a mitotic index of 13 and 10 400x high power fields. Treatment options discussed included palliative medical management, radiation therapy, chemotherapy, and palliative surgery. The owners elected to pursue surgery due to the anorexia, pain, and lameness, and a CT scan was performed for further staging and planning purposes. A pre and post contrast CT scan was performed under general anesthesia and demonstrated a 6.1 by 4.1 by 4.3 centimeter peripherally contrast enhancing mass centered over a dorsal aspect of the right iliac wing with extensive bone lysis to the iliac body, wing, and sacrum, along with an expansile, ill-defined periosteal reaction associated with the mass. There was also extension into the right sacral foramen, vertebral, and pelvic canal caudal to the sacrum. The right medial iliac lymph node was moderately enlarged and heterogeneously contrast enhancing. The mass was quite extensive, and palliative cytoreduction with en-bloc resection was discussed with a plan for a right-sided amputation with mid to cranial hemipelvectomy and hemisacrectomy as demonstrated by the blue hash marks. Risks and complications associated with the procedure included anesthesia, hemorrhage, thromboembolic disease, healing complications, pain, possibility for reconstruction, tail issues, tumor recurrence, metastasis, contralateral lumbosacral instability, and limb paralysis, either from trauma or myomalacia, and death. The other concern was incontinence. As demonstrated by the image in the middle, the pudendal and pelvic nerves originate from the S1 and S3 spinal cord, and the hypogastric nerve originates from the L1 to L2 TL spine, and they merge at the pelvic plexus before innervation of the bladder neck. As for fecal function, branches to the rectum arise from the pelvic plexus, and resection of the hemisacrum left the potential for iatrogenic neurotrauma to the lumbosacral nerves and potential for urinary and fecal incontinence. Another concern was the paucity of literature on outcome with hemisacrectomy and/or hemipelvectomy. Kuntz reported traumatic axial sacral fractures were more likely to present neurologic detriment initially, but had significant improvement long term. Since hemisacrectomy is axial in nature, the possibility of urinary and fecal incontinence could not be ignored. To the best of our knowledge, Straw's group were the first to report on a hemisacrectomy for chondrosarcoma in the right ilium of a 5-year-old Labrador retriever, depicted here with the shaded areas, with complete surgical margins achieved, no local recurrence, and survival time longer than 40 months with death unrelated to disease. Niles reported on total hemipelvectomy with sacral nerve transection and lumbar plexus en-bloc resection for a nerve sheath tumor with clean margins in an asymptomatic patient at 16-month follow-up. Kramer's group then described patient selection, surgical technique, and postoperative care for hemipelvectomy patients and commented that recurrence is higher with incomplete resection due to more medially located tumors. In the largest hemipelvectomy study to date, Jonathan Bray and group described the outcome of 84 dogs and 16 cats with 1-year survival time for cats being 75%. The disease-free interval for dogs was 257 days. Median survival times for canine tumors were more than 1,200 days for chondrosarcoma, 530 days for osteosarcoma, 370 days for soft tissue sarcoma, and roughly 180 days for hemangiosarcoma. Large tumors, tumor location, and anatomic limits of sacral or lumbosacral plexus tumors were likely to lead to incomplete resection. Barber's group then described the anatomy, technique, and outcome of hemipelvectomy in 4 dogs and 5 cats, with the majority of cases ambulatory without assistance. Since then, 4 case reports have described different pelvectomy strategies, including initiectomy for grade 1 chondrosarcoma with complete resection and long-term survival by Allblock et al., pubectomy and stereotactic radiation therapy for a non-resectable sacral osteosarcoma as a viable option for urinary and fecal obstruction as reported by Randall et al., hemipelvic and femoral limb salvage endoprosthesis for a left coxofemoral histiocytic sarcoma that resulted in a 14-month survival period, no implant-associated complications, and minor neuropraxia for 14 weeks postoperatively by Fitzpatrick and group. And lastly, an ileectomy with limb preservation for an osteosarcoma, which was preferred over an external pelvectomy as medial surgical margins were unlikely to be achieved. This patient survived 430 days and was euthanized due to local recurrence and pain. However, owner satisfaction was excellent in a follow-up phone call, despite initial contralateral ischial fracture and pelvic canal narrowing as reported by Alberto et al. In human literature, iliosacral ostectomy is performed for extensive pelvic tumors with increased morbidity noted as a result of pain associated with reconstruction. In a retrospective study by Kayatsiva in the Journal of Clinical Orthopedic Related Research in 2017, looking at the functional outcomes after total sacrectomy without spinal pelvic reconstruction, 13 of 16 patients were able to walk following total sacrectomy, with 10 patients independently with or without walking aids. On the day of procedure, a PCV was 20% and a pre-op packed red blood cell transfusion was performed. General anesthesia was performed with an epidural and placement of an indwelling urinary Foley catheter. Here, the previous biopsy site is distal to the marking on the IO band dressing. A right-sided coxofemoral disarticulation is performed, including the biopsy site, with an attempt made for preservation of the semitendinosus muscle for reconstruction later. The right acetabulum is visualized, and an Army-Navy retractor is used to protect the right sciatic nerve in preparation for mid to cranial hemipelvectomy. An acetabular osteotomy is created using an oscillating saw and is depicted here with forceps, as is the sciatic nerve with the black arrow. Tissue dissection was continued further cranial at the ilial wing and included the paraspinal muscles of the L6 and L7 right vertebra. Next, the ilial mass is retracted with the periosteal elevator laterally, and a sacral laminectomy is performed with a high-speed burr dorsally. There was inadvertent trapping of the cauda equina on this side during burring. Next, an osteotome and mallet were used ventrally through the sacral body to complete the hemisacrectomy. The ilial mass is then reflected and removed with exposure of the remaining surgical field depicted here. Grossly, some tumor capsules believed to remain medially. The right medial iliac lymph node was unable to be identified, and unfortunately, the semitendinosus muscle became non-viable and was transected. Vascular hemoclips were applied for hemostasis and marking the extent of the surgical field. A pain soaker catheter was placed for postoperative analgesia, and indwelling closed suction Jackson-Pratt drain was incorporated into subcutaneous and skin closure. The final closure is visualized here. Postoperative orthogonal pelvic radiographs performed revealed a right hemisacrectomy with mid to cranial hemipelvectomy and amputation in the two images on the left. Toby recovered uneventfully from anesthesia. However, he was hypoglycemic and required a 2.5% dextro CRI. He was also started on appetite stimulants and was eating and euglycemic within 1 day of surgery. Toby was ambulatory within 24 hours, as depicted on the right, as urinary catheter was removed and complete urinary and fecal continence was retained. By day 3 post-op, a left pelvic limb Godet sign was noted, presumed to be due to gravity-dependent edema contributing to minimal Jackson-Pratt drain production. Also by day 3, Toby was ambulating well on his own but had lost all tail function. He was discharged on day 4 post-op. The final histopathology of the mass revealed an infiltrative subcutaneous hemangiosarcoma with extension throughout the skeletal muscle and invasion of the bony pelvis. Margins varied from 15 to 18 millimeters at the haired skin, with bony margin from the iliac crest being 12 millimeters longitudinally and 4 millimeters transversely. The longitudinal section of acetabulum demonstrated a margin of 15 millimeters, and deep soft tissue margins were less than 1 millimeter. Mitotic index was 24 per 10 Howard parafields examined. At incisional recheck depicted on the left, Toby reported to be eating and ambulating well. Serial CT scans were performed over the course of the next 75 days, and the middle image is a 3D reconstruction with the caudal vertebra of the tail rendered. Progressive CT scans revealed pulmonary metastasis, as seen in the image on the right with the green arrows. There was also a cystic hepatic lesion, as seen in the image on the right with the red arrow, and intracapsular fluid denoted progressive metastatic disease, same image, green arrow. And finally, the soft tissue surrounding the hemisacrectomy site appeared mottled and thickened with suspicion for local recurrence. Toby received 2 cycles of doxorubicin, but due to metastasis throughout visits, a new protocol of vinblastine and propranolol was initiated with no adverse effects noted. Physical exam findings during these sessions revealed a progressive fluctuant 2.2 by 3.2 centimeter swelling at the distal extent of the pelvectomy site, with a new skin nodule at the cranial extent, but these were not sampled. 74 days postoperatively, another CT scan performed revealed progressive metastasis, and Toby was reported to be lethargic that day with inaptitude and development of soft stool, and he was humanely euthanized 2 days later. Toby had a survival time of 76 days postoperatively, and this is consistent with previously reported outcomes. In a study by Hillers and Jaha 2007, 4 similar non-splenic hemangiosarcoma masses in dogs of the right tail base, left thigh, left flank, and right rump were treated with some combination of palliative radiation therapy, doxorubicin, and surgery with survival times of 74, 42, 112, and 6 days respectively. Overall, 20 dogs were treated with palliative radiation therapy with a median survival time of 95 days in a range of 6 to 500 days. In a study by Bulakowski and Javma 1 year later, 21 dogs were treated with 3 to 6 cycles of adjuvant doxorubicin for subcutaneous and intramuscular hemangiosarcoma, with the subcu hemangiosarcoma having a significantly longer disease-free interval than the intramuscular hemangiosarcoma, 1,500 versus 265 days respectively, and longer median survival times, 1,180 versus 272 days respectively. Toby's tumor was finalized as subcutaneous. However, there was extensive musculoskeletal infiltration and bony invasion, making it plausible that his tumor could have originated from the muscles based on the aggressive biology. Complications reported with our procedure included a blood transfusion, hemorrhage, semitendinosus muscle flap loss, iatrogenic cauda equina damage to the tail, post-op hypoglycemia, and cell-resolving edema. Post-op recovery and quality of life was excellent as he remained ambulatory with rapid return of appetite, no urinary or fecal incontinence, and no incisional site complications. The owners were happy with the immediate results of the procedure. As far as we are aware, this is only the second reported case of a hemisacrectomy in veterinary medicine. In our case report, the postoperative morbidity was similar to that of an amputation alone. In future hemisacrectomy were to be performed, patient selection, knowledge of neuroanatomy, and careful surgical technique are of utmost necessity to prevent neurotrauma and to minimize the risk of local recurrence. These are our references. And with that, I want to thank Dr. Chris Hoffman for surgical assistance, Dr. Nakia Stewart for imaging analysis, Dr. Jessica Smith for case write-up, and Dr. Pierre Amselem, my mentor and primary surgeon for Toby's case. And thank you to the Society of Veterinary Soft Tissue Surgeons for allowing me to present this unique case today. And with that, I will take any.
Perioperative ventricular arrhythmias are common in dogs undergoing splenectomy, and they've been reported to occur in 28 to 44% of dogs undergoing this procedure. In several smaller studies, perioperative ventricular arrhythmias have been found to be more common in dogs with hemoperitoneum, anemia, hypotension, and metastatic myocardial disease. One larger study evaluating risk factors for mortality found that intraoperative ventricular arrhythmias increased the odds of death 3 times over dogs that did not have intraoperative ventricular arrhythmias. The objective of our study was to evaluate a large number of dogs to identify risk factors for perioperative ventricular arrhythmias in dogs undergoing splenectomy for splenic masses. We also aimed to identify risk factors for in-hospital mortality. Our hypotheses were that dogs with anemia, thrombocytopenia, hemoperitoneum, or hemangiosarcoma would be at increased risk of perioperative ventricular arrhythmias, whereas we thought that the presence of perioperative ventricular arrhythmias would also increase the risk of in-hospital mortality. This was a retrospective case review done at the University of Georgia, including cases seen from January 2010 through December 2018. All dogs underwent a complete splenectomy for a splenic mass, and records were evaluated for signalment, blood work, imaging, surgical findings, histopathology, and outcome. Ventricular arrhythmias were classified as being pre, intra, or postoperative, and specific exclusion criteria included dogs undergoing a partial splenectomy, those that had intraoperative euthanasia, and those that had no or only intermittent postoperative ECG monitoring. Continuous variables were evaluated with nominal logistic regression, and categorical variables were evaluated with a Fisher's exact test. Multivariable analysis was performed via binary logistic regression with a backwards elimination, and p-values were set at less than 0.05. Overall, we had 332 dogs included in the study, including 130 females and 202 males. The median age was 11 years with a range of 2.8 to 17 years of age. And the median weight was 25.5 kilograms with a range of 1.6 to 69 kilograms. The four most common breeds that were represented included mixed breed dogs at 21%, Labrador Retrievers at 14%, Golden Retrievers at 7%, and German Shepherd dogs at 4%. 37% of dogs had a hemoabdomen, while 63% of dogs did not have a hemoabdomen. Overall, 49% of dogs were diagnosed with a benign condition, and 40% were diagnosed with hemangiosarcoma, while 11% were diagnosed with an other malignancy. The most common diagnoses in dogs with benign conditions were hematoma, extramedullary hematopoiesis, and nodular hyperplasia. And the most common other malignancies included lymphoma and sarcoma. In dogs that did not have a hemoabdomen, 64% of those dogs had a benign condition on histopathology, 20% were diagnosed with hemangiosarcoma, and 16% were diagnosed with other malignancies. For dogs with hemoabdomen, 23% had a benign condition, 73% had hemangiosarcoma, and 3% were diagnosed with other malignancies. Overall, 9% of dogs had preoperative ventricular arrhythmias, 16% had intraoperative ventricular arrhythmias, 41% had postoperative arrhythmias, and 6% of dogs had in-hospital death. Moving forward, all of my results will be presented in this format with the variable at the top of the screen, and then a chart with preoperative, intraoperative, postoperative ventricular arrhythmias and death in the first column. These will remain color-coded throughout the presentation. The second column includes the value for that variable in the group with ventricular arrhythmias or death, whereas the third column includes the value in the group without ventricular arrhythmias or death. The next column is the odds ratio. For many factors, this is a unit odds ratio, but for some it made sense to convert the unit instead of being 1 to a more realistic unit for that variable, and so I will highlight those as we move through. And the p-value is listed in the last column. Dogs with a higher body weight had an increased risk of having preoperative, intraoperative, and postoperative ventricular arrhythmias, but body weight was not significant for mortality. For every 10 kilogram increase in body weight, the risk of having a perioperative arrhythmia increased by 40 to 62%. Dogs with a higher heart rate also had an increased risk of pre, intra, and postoperative arrhythmias and also death. For dogs with an increased heart rate, they had a 30 to 42% increased risk of having perioperative arrhythmias and a 40% increased risk of having in-hospital mortality. Dogs that had a lower blood pressure on admission were more likely to have intra and postoperative ventricular arrhythmias, and the risk of having those arrhythmias increased by 10 to 20% for every 10 millimeters of mercury that the blood pressure was lowered on admission. Dogs with a lower PCV also had an increased risk of having pre, intra, and postoperative arrhythmias and death. For every 5% decrease in the PCV, the odds of having a perioperative arrhythmia increased by 20 to 45%, and the odds of having death in hospital increased by 40%. Dogs that had a lower platelet count on admission also had an increased risk of having pre, intra, and postoperative arrhythmias. And for every 20,000 decrease in the platelet count, the odds of having perioperative arrhythmias increased by 10 to 16%. Dogs that had a longer duration of hypotension under anesthesia were also more likely to have pre- and intraoperative arrhythmias and in-hospital death. And dogs that had pre- and intraoperative arrhythmias had a 13 to 14% increased risk of having that condition for every 10 minutes duration of hypotension under anesthesia. And the odds of death increased by 13% for every 10 minutes of hypotension under anesthesia. Dogs with hemoabdomen were also more likely to have pre, intra, and postoperative arrhythmias and in-hospital mortality. Dogs that had a hemoabdomen had a 3 times odds of having preoperative ventricular arrhythmia, whereas dogs with intra and postoperative ventricular arrhythmia had an increased 6 to 7 times increased odds. Dogs with a hemoabdomen had a 3 times increased odds of having in-hospital death. Dogs that received a blood transfusion throughout any part of their hospital stay had an increased risk of having intra and postoperative arrhythmias and death. And so for dogs that had transfusions, there was a 3 times increased risk of having intra and postoperative arrhythmias. And for dogs that received a transfusion, there was a 9 times increased odds of having in-hospital mortality. Additional risk factors for mortality that were identified included the presence of both intra and postoperative ventricular arrhythmias. So dogs that died in hospital had a 3 to 4 times more likely, were 3 to 4 times more likely to have intra or postoperative arrhythmias. Multivariable analysis was only able to be run on postoperative ventricular arrhythmias due to not having enough patients in each category to evaluate the other outcomes. Overall, having an increased body weight, an increased heart rate on admission, and the presence of a hemoabdomen were all significant for having postoperative ventricular arrhythmias on multivariable analysis. Dogs with hemangiosarcoma were more likely to have preoperative ventricular arrhythmias than dogs with benign conditions, with 14% of dogs with hemangiosarcoma having preoperative arrhythmias compared to only 6% of dogs with benign conditions. They were also more likely to have intraoperative arrhythmias compared to dogs with both benign and other malignant conditions, with 26% of dogs with hemangiosarcoma having intraoperative arrhythmias compared to only 11% of dogs with benign conditions and 3% of dogs with other malignancies. Dogs with hemangiosarcoma were also more likely to have postoperative arrhythmias compared to both benign and other malignant conditions, with 58% of dogs with hemangiosarcoma having postoperative arrhythmias compared to 31% of dogs with benign conditions and 22% of dogs with other malignancies. Dogs with hemangiosarcoma were also more likely to have in-hospital mortality compared to dogs with benign conditions, with 10% of dogs with hemangiosarcoma having death in hospital compared to only 3% of dogs with benign conditions. Overall, factors significant for perioperative ventricular arrhythmias and death were all consistent with the presence of a hemoabdomen, including tachycardia, hypotension, anemia, and thrombocytopenia on presentation, the need for a blood transfusion, and a final diagnosis of hemangiosarcoma. This is consistent with previous reports that also found that hemoperitoneum, anemia, and decreased intraoperative blood pressure were significant for the presence of perioperative arrhythmias. Additionally, we found that increasing body weight and a diagnosis of hemangiosarcoma were significant for having perioperative arrhythmias. Our findings for mortality were also consistent with previous reports in terms of the presence of intraoperative arrhythmias and anemia increasing the risk of in-hospital mortality. Previously, thrombocytopenia had been found to be a risk factor for mortality, but that was not confirmed in this study. However, we did find that the presence of postoperative ventricular arrhythmias did increase the risk of in-hospital death. I'd like to take a minute to talk about the double 2/3 rule, which we're all familiar with when talking to owners of dogs with splenic masses. And this rule states that 2/3 of dogs with splenic masses will have a malignant lesion, and 2/3 of those will be hemangiosarcoma. Using the data from this study, for dogs with a hemoabdomen, 76% had malignant neoplasia, and 96% of those had hemangiosarcoma. In dogs that did not have a hemoabdomen, 64% had a benign condition and 20% had hemangiosarcoma. This is consistent with a recent report that evaluated dogs with splenic masses without hemoabdomen that found that 70% of dogs had a benign condition. Limitations of this study include its retrospective nature and the inability for us to go back and evaluate the severity of postoperative arrhythmias, and any response to antiarrhythmic treatment. These will be the focus of future prospective studies to evaluate this further. I'd like to thank Alicia Michael, who's going to be the lead author on the paper from this study. She's currently finishing her internship at the University of Florida, and she'll be moving on to the University of Minnesota for her surgery residency, so we're very excited for her. And I'd also like to thank one of our current fourth-year students, Meenakshi Rajiv, because both she and Alicia spent numerous hours going through over 400 records to identify dogs for this study and collect their data. I'd also like to thank my colleagues, Mandy Wallace and Chad Schmidt, for their assistance with this study. And at this time, I'd be happy to take any questions.
So as we all know, splenic pathology is quite common in dogs, and this can represent benign or malignant focal lesions or lesions, multifocal lesions throughout the spleen. We know based on previous studies that about half to 2/3 of all lesions we detect in the spleen will come back as malignant on histopathology. The most common malignant lesion we see in the spleen of a dog is hemangiosarcoma. And when there is no hemoabdomen present in these patients, we can expect that about 22 to 46% of them will be hemangiosarcoma, versus if there is a hemoperitoneum present, that prevalency goes up quite a bit. And it reaches 61 to 76%. It is common to detect lesions in the liver at the time of diagnosis, and we'll see that in about 50–60% of cases, although true liver metastasis has been reported in the literature of anywhere from 21 to 48%. Findings that have been reported that are suggestive of hemangiosarcoma in the literature, so multiple studies have looked at trying to predict this pre-histopathology. Some of these findings are clinical pathologic data such as anemia, abnormal red blood cell morphology, low total solids, and thrombocytopenia. In addition, some imaging characteristics have been identified such as hemoperitoneum, small splenic mass to splenic volume ratio. On CT scan, they have noted that hemangiosarcoma has a low Hounsfield unit attenuation value, and they set that number at about less than 55. And in addition, Cucovio and VetRad ultrasound in 2002 evaluated target lesions within the spleen and the liver. And this is an image from that study where you can see these target lesions that are left that are very representative of what they were evaluating in the study. And that was also suggestive of hemangiosarcoma. In addition, low splenic weight as a percentage of body weight has been supportive of hemangiosarcoma. It is important to note that the splenic mass to splenic volume ratio and the splenic weight as a percentage of body weight, those factors were evaluated in the Mallinckrodt study in JAVMA in 2011. And in that study, although that was statistically significant for hemangiosarcoma, those factors were not significant between benign and other malignancies than hemangiosarcoma. So you could still have a malignant lesion in a spleen that was a single large splenic mass. So that's really important to remember for our patients. There is limited information available on the use of MRI for evaluating splenic lesions in dogs. Clifford out of JVIM in 2004 did evaluate focal hepatic and splenic lesions, although in that study they only had 8 splenic lesions total and only one of those was malignant. So it's really hard to compare that to our population and give us any idea of what we truly would expect as far as malignancy goes, although that study did report pretty high accuracy of predicting that. EUVIST is a liver-specific contrast agent that is available in the literature to evaluate. And essentially, this contrast agent is taken up by normal hepatocytes from the venous system, and then it is excreted into the biliary tree. So in the CONSTANT study in VetRad and ultrasound in 2016, what they noted was that the malignant lesions in those studies, which were all hepatocellular carcinoma of the liver, did have reduced or delayed contrast uptake. So they were different than the surrounding tissue. And then in that study as well, the CONSTANT study, they did note that MRI likely allowed the detection of lesions that weren't otherwise visible on ultrasound, which is helpful. So with all that information, we decided our study objectives should include identifying features of malignant splenic masses present on MRI and comparing those features with the histopathologic results that we would obtain. We also wanted to evaluate any liver masses noted on MRI with the use of the EUVIST contrast agent. And then finally, we wanted to compare the number of lesions within the liver and the spleen to the ultrasonographic number that were noted before MRI was performed, and then compare those results to the diagnosis of malignancy. So the hypotheses of this study included that benign and malignant splenic lesions would differ in their signal characteristics in both pre and post-contrast sequences on MRI. And in addition, that we would be able to identify metastatic liver lesions at a more enhanced rate using the EOVIS contrast agent to help give us a better idea of malignancy. So for statistical analysis in this study, we did start with a power analysis. A power of 0.8 when the alpha was 0.05 allowed us to determine that we needed at least 24 subjects total for this study to have any significance. It was a prospective cohort study, and the inclusion criteria was essentially that a dog had a splenic lesion that was diagnosed with ultrasound, and that those ultrasound images were available for review with the radiologist within our hospital. So she wasn't necessarily performing every ultrasound, but she absolutely evaluated every image. The owners also had to consent that following MRI, they would allow us to either take their patient to surgery for surgical splenectomy or perform a necropsy to obtain the histopathology samples that were required based on MRI imaging. So in general, following the ultrasound and owner consent, dogs were placed under general anesthesia for abdominal contrast-enhanced MRI. The pre-contrast images obtained included the T1 weight spin echo, the T2, the T2-T1 coherent gradient echo, or called the FISP, and the T1 3D gradient echo, or the VIBE. We would then administer the EOVIS contrast agent at a dose of 0.1 mils per kg IV, and then obtain our post-contrast images, again, using the T1 3D gradient echo, or the VIBE. We would obtain that immediately after contrast administration, then every 5 minutes for 20 minutes to evaluate how that contrast enhancement changed over time. Immediately following MRI, the dogs were either sent to surgery or they would be euthanized to obtain histopathology samples via that route. Prior to surgery, the radiologist would consult with the surgeon that was operating the case to identify areas of concern regarding the liver parenchyma, suspicious lymph node, or lesions within the omentum that they would try to target biopsy. There would be a complete splenectomy performed in all cases for histopathologic analysis, and at the surgeon's discretion, additional biopsies would be taken. All samples would be submitted to a single pathologist for review for histopathology, and she had a very consistent histopathology sample protocol. So essentially, looking at this image here, what we would do is take a cross section through the splenic mass, a longitudinal section through the splenic mass, and then we would take an additional section through the normal and abnormal splenic tissue interface. If in these cases we determined that the mass was benign, she would then go and look at the sample and take 3 to 4 more representative sections through areas of interest and just confirm that it was truly benign and not malignant in character. With all of this information together, we then use the Fisher's exact test to evaluate associations between the tumor type diagnosis, so malignant or benign, and numerous categorical variables with the significance identified at 0.05 or less. We also use logistic regression analysis to, again, evaluate associations between tumor type, but then the numerical variables in this study. Significance was set at the same. And then factors that we use to evaluate for statistical analysis, either the Fisher's exact or the logistic regression analysis, included signal characteristics on MRI, degree of heterogeneity of the tumor, signal intensity ratio, degree of contrast enhancement, the size of the lesion, so the biggest lesion in the spleen and the largest dimension was documented, as well as the number of masses within the splenic tissue itself. We also identified other lesions on MRI and used that in analysis, and diagnosed the presence of hemoperitoneum in our analysis as well. So in total, 25 dogs were enrolled in this study. Mixed breed dogs were the most represented at 6. And most of these dogs were either medium to large size, so they were all over 17 kilograms. We did have a golden retriever, a Labrador, and basset hound. Those breeds were represented at 2 dogs each, and then a variety of other breeds were represented at a single dog each. About half of those were small, and about half of those were larger giant breed dogs. The median weight of dogs in our study was just under 26 kilograms, and the median age was around 10 years old. Only 36% of our cases did present to the hospital, and get enrolled into our study as an emergent status. The rest of these cases were planned or elective procedures. And then prior to MRI, hemoperitoneum was detected in 4 total dogs. And we had thoracic radiographs present for evaluation in 23 dogs. And in those 23 cases, only 4 of them were abnormal. So 3 dogs had sternal lymphadenopathy and a single dog had a single pulmonary nodule. Splenic histopathology in this study was resulted out as 44% being malignant and 56% being benign. It is important to note that all of these samples were obtained via surgical analysis, so no patient was euthanized and had samples obtained via necropsy. These were all surgical explorations with samples obtained via that route. Of the malignancies, 5 out of 11 of them were hemangiosarcoma, so similar to other studies. About 50% of our cases were malignant and about 50% of those were hemangiosarcoma. The other tumor types or malignancies represented included fibrosarcoma, stromal cell sarcoma, or stromal sarcoma, liposarcoma, and 1 undifferentiated sarcoma. When evaluating the number of splenic masses in the spleen itself, a majority of dogs did have a singular splenic mass. The next most common number type was 2 to 4 masses within the spleen, and that was about 8 of our patients. And this was not statistically significant with a diagnosis of malignancy. The largest splenic mass within the spleen by dimension, so the overall in this group of dogs, the mean size was 11.7 plus or minus 6.1 centimeters, and this was not statistically significant. And if we were to separate those 2 groups out within the malignant mass group, the median size of the splenic mass was about 10 centimeters. And in the benign group, the median size of the splenic mass was about 11.5 centimeters. Again, the heterogeneity that we evaluated and that we mentioned that we were evaluating was diagnosed either from 1 to 3. So 1 being the least heterogeneous, 3 being the most. This was not statistically significant with the diagnosis of malignancy. But you can see that it's pretty well represented through the group, except that with the heterogeneity level 1, that was much more likely to be benign in this category, but overall this was not statistically significant. This is a chart of our MRI signal characteristics that will help guide us through this information. So for all the scan sequences that we did, the only significant sequence that we found statistically was the T2 sequence. And in this sequence, what you'll notice, or what is important to point out, is that malignant splenic masses were either hypointense or hyperintense or mixed, and benign splenic masses were either hypointense or mixed. So there were no malignant masses that were hypointense and no benign masses that were hyperintense. We also did approach significance with the FISP sequence, but it did not reach significance in this study. So this is an MRI view of a dog with a benign hematoma. You can see in this splenic mass, it is diffusely round hypointense lesion. This next image is a dog diagnosed with an undifferentiated sarcoma, and we have a diffusely hyperintense lesion within the spleen. And we also have an abnormal lymph node as well as a nodule within the omentum there. The presence of liver nodules was noted on ultrasound in 7 dogs and on MRI in 5. 3 out of 5 of the dogs had liver nodules noted on MRI only, so it was a different group of dogs in general. And interestingly, histopath showed that only 1 of 7 ultrasound lesions showed malignancy versus 3 out of 5 of the MRI lesions which showed malignancy. The presence of abnormal lymph nodes was noted in 7 dogs. Only 1 of them was metastatic, and this was not statistically significant for the outcome of malignancy. 2 dogs were noted to have peritoneal or omental nodules on MRI, and both of these were metastatic lesions. And then abdominal effusion was detected on MRI in 9 dogs, and 7 out of 9 of these did have malignant histopathology. So that brings us to our statistical significance here, which is that the presence of liver nodules on MRI alone was statistically significant with malignancy, as well as the presence of abdominal effusion was statistically significant. So similar to other reports that we are all aware of, abdominal effusion is still statistically significant or suggestive of malignancy in dogs with a splenic lesion. Liver nodules were noted on MRI in this study to be most often malignant on histopathology and statistically associated with malignancy as well. So interestingly, our radiologist noted that in a lot of these dogs, this is an MRI view of a dog with multifocal or diffuse nodular lesions within the liver that were malignant. And in this case, and in most cases, what she said is that a lot of these lesions were detected pre-contrast. So we may not even need the EUVIS contrast to detect these lesions in our patients. As well, looking at this imaging, it would be easy to suspect that we may not be able to biopsy all of these lesions that are directly pointed out on MRI. So some of our biopsies may not have been truly representative of what they were showing us on MR. The size and the number of splenic masses within the splenic tissue was not predictive of malignancy in this population. So similar to some other reports and maybe refuting another is that you can't predict whether or not this is benign or malignant tumor, whether it was hemangiosarcoma or other, with just based on the size and the number of splenic masses. And then our T2 sequence may help predict malignancy in this population. So if you'll remember, no malignant mass was ever hypointense on the T2 sequence and no benign mass was ever hyperintense. Although they both had a significant number that were mixed in population, those two characteristics could really clue us in that we're dealing with a benign or malignant disease. And then our FISP sequence does need further investigation, potentially with a larger number of cases as it did approach significance in this study. So in conclusion, we did have a small number of cases, which is common with prospective studies, but may lend us to a type 2 error, and we may not find significance where there truly is some. We also noted that although we did biopsy lesions other than the spleen, we may not have directly biopsied what the radiologist recommended that we do. We are limited to the surgeon's ability to do a gross inspection and detect these lesions in surgery based on the guidance of the radiologist, but we may not have reached all the lesions that we had hoped. But interestingly, I think we can suspect that any lesions noted in the liver on MRI may be more representative of a truly malignant lesion in these cases. And then finally, our sample population was not perfectly representative of clinical scenarios. So we couldn't enroll consecutive cases because some of them would present to the hospital at 2 a.m. and not be available for MRI. And some of them were so cardiovascularly unstable that the additional hour to 45 minutes of anesthesia was not safe for them to undergo for the scan. So in conclusion, I think MRI does offer additional information to the clinical challenge of trying to diagnose whether or not a splenic lesion is malignant without histopathology. I think we can accept our hypotheses that we did know additional liver nodules on MRI compared to ultrasound, and that there were some sequence differences, characteristics noted on the T2 scan that would lean us to whether or not a lesion is truly malignant or benign. We can say that abdominal effusion consistently through much of the literature is predictive of malignancy. And I think that we need some additional information to investigate the role of MRI in splenic disease. If these patients are unstable to undergo that anesthesia, should we be reserving this for elective cases? But maybe those are the cases where it is most pertinent for us to decide whether or not these are malignant or benign lesions. And I'd like to thank the SVSTS for providing this virtual meeting and allowing us to still present our research. It's really great that this is an option. My co-investigators for helping me complete this study. I couldn't have done it without them for sure. And then the Companion Animal Grant Fund for supporting the study itself. And I'll be happy to entertain any questions at this time.